Welcome to Roadmap to Residency. Hello everyone, I am Abhiraj. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on a journey to a 250. Which of the following liver lobes is most likely enlarged in this patient, and what anatomical feature separates it from the remainder of the liver? During a routine physical examination, a 55-year-old man presents with a mildly distended abdomen. The healthcare provider suspects hepatomegaly and orders an abdominal ultrasound. The ultrasound reveals an enlarged liver but no evidence of focal lesions or vascular abnormalities. Upon further testing, or upon further questioning, the patient mentions a history of heavy alcohol use and states that he has been experiencing right upper quadrant discomfort. Which of the following liver lobes is most likely enlarged in this patient, and what anatomical feature separates it from the remainder of the liver? The right lobe, falciform ligament; left lobe, round ligament; quadrate lobe, ligamentum venosum; quadrate lobe, ligamentum teres; right lobe, ligamentum venosum. So the most likely liver lobe to be enlarged in this patient is right lobe, and the anatomical feature that separates it from the remainder of the liver is the falciform ligament. So the key points to consider in this question is that the patient has an enlarged liver. The patient presents with hepatomegaly as confirmed by abdominal ultrasound, indicating that one of the liver lobes is enlarged. History of heavy alcohol use. The patient's history of heavy alcohol use raises concern for alcoholic liver disease, which commonly affects the right lobe of the liver. Right upper quadrant discomfort. The patient's complaint of right upper quadrant discomfort is consistent with hepatomegaly involving the right lobe. Falciform ligament attaches the liver to the anterior abdominal wall and separates the right lobe from the left lobe. But we know in my class, we don't only discuss about the question, we also go in detail inside the theory part. Now let's discuss about the anatomy of the liver. Now, this you can see is the inferior vena cava. And here, this is the falciform ligament, and the extension here is called the teres ligament. Also, this is the bigger one, right lobe, and this is the left lobe. And the right lobe and the left lobe are separated by the falciform ligament, as discussed in our question. Now, this one, a chordate-like structure is called as the chordate lobe, and the extension is called as the chordate process. And just beneath the bile duct, here we have the quadrate lobe. Okay, the quadrate lobe is just 1, 2, 3, and 4. So 4 sides quadrate lobe. And another thing you can see that here this is the coronary ligament, not so clinically important structure. But yeah, what you need to do is that you need to learn is that the right lobe and left lobe is separated by the falciform ligament. The right lobe is the bigger one, and then you have the chordate lobe above the bile duct and the chordate lobe below the bile duct. Now, what is important in the liver anatomy is the liver tissue histology. So the functional unit of the liver is made up of the hexagonally arranged lobules surrounding the central vein with portal triads on the edges, consisting of a portal vein, hepatic artery, and bile ducts, as well as lymphatics. So portal vein, hepatic artery, bile ducts, and some lymphatics. The apical surface of the hepatocytes faces bile canaliculi, and basolateral surface faces the sinusoids. The Kupffer cells are the macrophages of the liver, which are located in the sinusoids and clear the bacteria and damaged or senescent, also clear the damaged or senescent RBCs. The hepatic stellate cells are present in the space of Disse, and they store the vitamin A when they are quiescent and produce extracellular matrix when they are activated. And these cells are responsible for hepatic fibrosis. Now, this information is quite important because sometimes the question just tells you or just gives you histology that hepatocytes have undergone fibrosis. Now, which cells are responsible for that? And then you need to answer the stellate cells or the ito cells. Or sometimes they also ask where are these ito cells are present, then you need to answer that they are present in the space of Disse. The dual blood supply to the liver is through the portal vein and the hepatic artery. The portal vein supplies the measure of the blood supply, that is 80%, and hepatic artery is by 20%. But there are few zones in the liver. Now, the zone 1 is called as the periportal zone, which is affected first by the viral hepatitis. Now, this is important. These zones, instead of remembering that where these zones are present, you need to remember that what these zones have a clinical significance to. So the zone 1 or periportal zone is affected first by the viral hepatitis. It is best oxygenated and most resistant to circulatory compromise. So whenever there is hypovolemic shock, then this zone 1 will not be affected. And the ingested toxins, example cocaine, they act most on the zone 1. The zone 2, remember easily, zone 2 is for the yellow fever. So yellow fever affects the zone 2 or the intermediate zone. Zone 3 is called as the central lobular zone, which is affected first by the ischemia. Now, this zone is the farthest from the, let me draw it for you. So, this is the zone 1, this is the zone 2, and this is the zone 3. Now, this zone 1 is the nearest. So, any circulatory compromise or like for hypovolemic shock will or a hypotension will not affect the zone 1. This intermediate zone will be little bit affected, but the most affected is this farthest zone, that is the zone 3. Okay, that's why it is very important thing, and it is consequently tested in the USMLE step 1 examinations, that whenever the patient is having hypovolemia, which cells have been affected or which zone have been affected, then you need to answer that the zone 3 have been affected. Let's let me erase this all. So now it has a high concentration of cytochrome P450 and is more sensitive to metabolic toxins like ethanol, rifampin, acetaminophen, and it is a site of alcoholic hepatitis. But what is the thing that the most important here is that zone 1 is affected by the cocaine-induced toxins. Zone 3 is affected first by the ischemia because it is the least oxygenated one. And let's also focus or zoom in into the histology, because here you can see that this is the portal vein, this collapsed zone is the hepatic artery, you can see some connective tissue here, and now here is the bile duct, and this is the interface between the two hepatocytes. Also, if you zoom in from the liver gross to the liver histology, first of all, you can see this is the gross liver, and then if you just zoom in, we have the liver lobules, and inside the liver lobules, we have this sort of structure. So when we take a cross section of the liver lobules, then we can see that this is the bile duct, this is the portal vein, and this is the branch of the hepatic artery. So the blood will pass from the portal vein or hepatic artery towards the central vein, and the bile production, that the bile is produced by the liver, should pass out from the liver in this way. So outward through the bile duct and inward through the portal vein and the hepatic artery. Now this is also the same thing. Here you can see this is the zone 1, this is the zone 2, and this is the zone 3. This is the artery and all. So this is the most perfused area, this is the intermediate, and this is the least perfused area. Talking about the blood supply, you can see we have the gallbladder, which is supplied by the cystic artery. Sometimes they ask you what blood vessel to ligate, so cystic artery, and then you have the left gastric artery, the splenic artery. So in case of splenic vein thrombosis, this is splenic artery may be dilated, tortuous, and so it is called as the splenic vein thrombosis. Sometimes whenever there is splenic vein thrombosis, then again due to the back pressure, then the splenic artery may also be dilated. Now, we just go through a very simple towards the complex one in my lecture. So here we will discuss about the bile circulation from production to elimination. So bile is created within the liver, and bile is comprised of water, bilirubin, and bile acids, which turn to the bile salts when conjugated to glycine or taurine. Secreted bile salts consist of 95% recycled and 5% newly synthesized bile salts. So you know that bile is created within the liver and is comprised of water, bilirubin, and bile acids. Okay, and which turn into bile salts. So these are mixed up and turn into bile salts, and when conjugated to glycine or taurine, uh, uh, when these molecules just gets conjugated to the glycine and taurine molecules, then it is forming the bile salts. And after that, the bile travels from the liver towards the gallbladder for the bile ducts, and then the gallbladder absorbs the majority of the water and stores the concentrated bile. You know that when the liver produces bile, then there is a higher concentration of water. You need to make this bile concentrated, and that's why when the bile is stored in the gallbladder, the gallbladder absorbs most of the uh, water and makes the bile concentrated. And then whenever the bile is needed, then the bile is released through the common bile duct into the duodenum in the portion of the small intestine. And the bile travels through the intestine, and then it just does its job. 95% of bile will be passively absorbed across the intestinal lumen and recycled back to the liver. And about 5% of the bile will continue to travel through the colon and is released by a fecal excretion, taking with it and eliminating the bilirubin and unwanted toxins. Now, let's review the first aid ones. So, heme is metabolized by heme oxygenase to biliary green, which is subsequently reduced to the bilirubin, which is yellow brown. And then the unconjugated bilirubin is removed from the blood by the liver, conjugated with, so it is conjugated with glucuronate and excreted in the bile. So the direct bilirubin will get conjugated, means that it is conjugated with glucuronic acid, which is water soluble and dissolves in the water. And the indirect bilirubin means it is unconjugated and it will not be water soluble, right? So RBC from heme produces unconjugated or indirect bilirubin, and then it just binds to the albumin and forms the unconjugated bilirubin albumin, and then it just goes into the liver and converts into the conjugated or direct bilirubin under the action of UDP glucuronidase transferase, and it gets conjugated with glucuronic acid, and then it just it just travels through the bile duct into the gut, and it just converts into urobilinogen. And then most of you know that most of the bile will be again reabsorbed and some will be excreted in the feces. If it gets excreted in the feces, then it is called as stercobilirubin. And if it is excreted in the urine, then it is called as the urobilirubin or urobilin. Now, again, cholesterol forms the primary bile acid, that is cholic acid and canodeoxycholic acid. And then the liver converts this into the secondary bile acids, the deoxycholic acid and lithocholic acid. And again, there is the formation of uh, bile salts where the bile acids conjugate with glycine and taurine. Then the gallbladder just concentrates it, and then it is secreted into the intestine. And with the bacterial action in the intestine, it gets again broken down, and then it is reabsorbed into the liver again back to the intestines, and instead it's some of the fecal loss, 10 to 20% of the pool per day. The portal circulation, it just happens 6 to 8 cycles per day, and this intrahepatic circulation means that circulation of the bile happening between the liver and the intestine, which is happening just like in this pathway. Very simple one. So again, this is the same one, but that's another picture. Cholesterol forms the primary bile acids in the liver, and then it is conjugated to form bile salts, and after that it just goes to the bile canaliculi, and it is into the stored in the gallbladder, and then it is again secreted into the intestine, and then there is the bacterial action which just breaks it down, and it gets excreted in the feces. The bile salt function is the emulsification and absorption of the fats. The primary bile acids by the gut flora change to the secondary bile acids and conjugation with glycine or taurine and give rise to the bile salts. Now let's move on to a different topic. So which phase of the hepatic detoxification is primarily impaired in this patient, leading to the accumulation of ammonia? So 50-year-old man with a history of chronic alcohol abuse presents to the clinic with signs of hepatic encephalopathy, including confusion and asterexis, Lab tests reveal elevated serum ammonia levels, which phase of hepatic detoxification is primarily impaired in this patient, leading to the accumulation of ammonia. Phase 1 reactions, phase 2 reactions, phase 3 reaction, phase 4 reactions, or phase 5 reaction. Now let's talk about the phase reactions of detoxification. So the answer is the impaired detoxification phase, primarily responsible for the accumulation of ammonia in this patient, is phase 2 reaction. So the key findings is that the chronic alcohol abuse. The chronic alcohol abuse can lead to liver damage, including alcoholic liver disease. The liver plays a crucial role in detoxifying the various substances, including ammonia. Hepatic encephalopathy. The patient's clinical presentation with hepatic encephalopathy, characterized by confusion and hysterexis, suggests impaired liver function and the subsequent accumulation of toxic substances in the bloodstream, such as ammonia. The elevated serum ammonia levels, lab tests revealing the elevated serum ammonia levels indicate that liver is not effectively metabolizing and detoxifying ammonia. Now let's talk about phase 2 reactions. What is phase 2 reaction? So phase 2 reactions in hepatic detoxification involve the conjugation of toxic substances with endogenous molecules, making them more water soluble and easier to excrete. One of the essential phase 2 reaction in ammonia detoxification is the conversion of ammonia into urea via the urea cycle. In individuals with hepatic dysfunction, this phase can be impaired, leading to the accumulation of ammonia. Let's talk about other phase reactions too. So phase 1 reactions involve oxidation, reduction, and hydrolysis reactions that transform the xenobiotics into more water-soluble molecules, which can then enter the phase 2 reactions. The impairment of phase 1 reaction is the least directly related to the accumulation of ammonia. The phase 3 reactions typically refer to the transport of metabolites and waste products out of the hepatocytes. So first you do the oxidation and hydrolysis, and then you make it more water soluble in the phase 2, and then in the phase 3 you just transport the metabolites and waste products out of the hepatocytes. So while impaired transport can contribute to the hepatic encephalopathy, it is not the primary phase involved in the ammonia detoxification. Then after that comes the phase 4 reaction. So it is not a recognized term in the hepatic detoxification. The phases are typically referred to as phase 1, 2, and 3, and the primary issue in this case is related to the phase 2 only. The phase 5 reactions is not a recognized term in hepatic detoxification, and it is not relevant to the accumulation of ammonia in this patient. So generally, the phases in the detoxification process by the liver are phase 1, 2, and 3. So in summary, the patient's hepatic encephalopathy and elevated serum ammonia levels are indicative of impaired hepatic detoxification, particularly in the phase 2 reactions that involve the conjugation of toxic substances. In the context of ammonia detoxification, this impairment can lead to the accumulation of ammonia and its subsequent neurological effects. Now let's talk about some of the phases of detoxification. We know that there is phase 1, phase 2, and phase 3. So phase 1 is by the P450 enzymes, and it involves the vitamins, minerals, branched amino acids, bioflavonoids, and glutathione. And then it forms intermediary or intermediate metabolites or the reactive molecules. And these reactive molecules, they may cause tissue damage or they may enter into the phase 2 reactions, okay, where it is again changed into a more water soluble forms, and through the phase 3 reactions it is now transported or excreted out from the body. Again, toxins which are fat soluble, phase 1. So enzymes and cofactors involved are riboflavin, niacin, pyridoxine, folic acid, vitamin B12, glutathione, branched amino acids. Phase 1 reactions involve the oxidation, reduction, hydrolysis, hydration, and dehalogenation. It forms the free radicals, and these free radicals can cause the tissue damage. And also the phase 1 forms the intermediary metabolites, which are more water soluble. And then the phase 2 reactions occur, and they change it into the excretory derivatives, which are transferred from the liver hepatocytes towards the excretory system, like in the intestine and feces and kidneys and the urine. So this is how the process of the detoxification occurs. Thank you for watching. Keep studying hard.